Hello, everyone. I'm Dr. Carmen Puliafito, and I'm here today with Professor Darius Moshfeghi of Stanford University, where he is director of the Retina Service. And we'd like to welcome you to Retina Synthesis.
Thank you, Carmen. It's a pleasure to be here, and it's nice to see you again.
We're going to talk today about some exciting new developments in the retinal pharmacotherapy of the retinopathy of prematurity, looking at Aflibercept. But before we get into the butterfly trial, can you just give us an overview of the current status of anti-VEGF therapy for retinopathy of prematurity?
Sure thing, Carmen. You know, back in 2005, shortly after you and Phil presented the bevacizumab data for us at the ASRS meeting in Montreal, in December of that year, we had the first case report of anti-VEGF with bevacizumab being successfully used in retinopathy of prematurity. And importantly, there was no adverse safety outcome. And that was what our big concern was. We thought it might work from an efficacy point of view, but we're worried in these tiny babies who have multi-organ failures, a lot of disease, a lot of morbidity going on, that it would be a large risk. Starting around 2010, Helen Hintz-Mittner started the BEAT-ROP trial, which was a multi-center trial in the United States using bevacizumab at 0.625 milligrams, randomized essentially 1-to-1, I believe, against laser photocoagulation. And they showed conclusively that in zone 1 eyes, which if you'll recall are the center of the bullseye, the central 30 degrees around the optic nerve, and are traditionally the babies that have the worst outcomes when treated with anything, whether it was cryotherapy or laser, that they had a 94% success rate with respect to anatomic outcomes, failure to develop retinal detachment, retrolental masses, or macular dragging or folds. And so this started a lot of interest because on the laser arm, they did very poorly. I mean, it was greater than 6-to-1 benefit in favor of bevacizumab. And so gradually over time, the pediatric retina community and the pediatric ophthalmology community gravitated towards using more anti-VEGF injections as opposed to laser therapy. And we had a strong bias towards those that were originally called aggressive posterior ROP or zone 1 eyes. And now those are called aggressive ROP eyes, which follow a non-traditional path, where they kind of skip all the stages and just start with very posterior disease and a lot of vascular activity characterized by plus. And we had really, pretty startling good results, such to the point where now at major academic centers here at Stanford and at Bascom Palmer, we now lead with anti-VEGF therapy. And both Nina Barakal at Bascom and myself here, we use 0.625 milligrams historically. And over time, what we've seen is that it does a very good job of knocking the disease down. And then they develop what's now in the international classification of ROP3 called peripheral avascular arrest. There's a lot of controversy in the field whether this needs to be dealt with. I'm in the group that agrees that it should be dealt with, and we hit it with laser at around 60 weeks to shut it down because the avascular retina is what's propagating the VEGF drive. And then others, and Nina's on that side, believe that we should just watch and see what happens. The trouble is that these are premature infants. There's a lot going on in their families. There's a lot of comorbidities, and you can run across a failure to follow up, which could result in an adverse outcome presenting into your clinic. And so those of us who are on the side of treating are using that as our primary motivator in that situation. Since then, we've seen Novartis introduce ranibizumab in Europe. They got a CE mark for ranibizumab at 0.4 milligrams. And then following that, we saw that both Bayer and Regeneron here in the United States tested 0.4 milligrams of Aflibercept against laser photocoagulation in a 3-to-1 randomization, essentially equivalent studies in the traditional treatment type 1 early treatment retinopathy of prematurity, which, if you may recall, is zone 1 with plus, zone 1 with stage 3, or zone 1 or 2 with stage 2 or 3 with plus disease. And then, of course, the aggressive posterior retinopathy of prematurity. Those were the treatment groups that were eligible, and they had a weight, minimum weight at the time of treatment so that the bioavailability of the drug would be low. So that brings us up to, angiogenesis when we were presenting the data on the Butterfly trial, which was the US-based arm of the Aflibercept outcomes.
So can you tell us about the Butterfly trial? How it was designed?
Yeah, so 3-to-1 ratio, and they were enrolling about 100 patients roughly, and you were looking at 0.4 milligrams dose with an outcome, a primary outcome of failure of reactivation of active retinopathy of prematurity at 52 weeks chronologic age, okay? And also with a failure of adverse anatomic outcomes. So you had 2 outcomes, okay? And adverse anatomic outcomes are what I elaborated previously, which are retinal detachments, macular dragging, and retrolenteral masses. So you had to have both. It wasn't an either or. And then you're comparing it against the laser photocoagulation. The children were randomized. They were treated within, the first 48 hours after that. And then they were followed every week, every 2 weeks, and they had photographic documentation. The main difference between the Butterfly, which was the US trial, and the Firefly was the outcome at which they were assessed for the primary outcome, the timing at which they were assessed, which in the US was 52 weeks chronologic, and in the Firefly trial was 24 weeks post-treatment. Essentially, that results in a difference of about 6 to 8 weeks, because we usually treat these children at around 32 to 34 weeks post-menstrual age. And so at 52 weeks, they would be somewhere around 28 weeks of age, and these would be 48 weeks chronologic at that point.
So what were the results?
So the results showed numerical superiority, but statistically, we didn't make the non-inferiority outcome. So it was about 78 versus 76% in the Aflibercept versus the laser group. Importantly, we didn't make it on the backside for the non-inferiority arm on the lower end of the bound in some kind of statistical assessment. But clinically, retinal detachments were worse in the laser photocoagulation group. The timing of the treatment procedure was dramatically different. It was basically 110 minutes versus around 10 minutes per patient. If you looked at it on a per eye basis, it was 70 minutes versus about 5 minutes for a eye basis per treatment. Most of the patients were bilaterally treated. And overall, the totality of both studies, the Firefly and the Butterfly trial, were put together in an FDA package, brought before the FDA. And about, 4 weeks ago, FDA approved this as the first pharmacologic treatment for retinopathy of prematurity here in the United States at the 0.4 milligram dose.
So will this replace Avastin?
It really comes down to individual treaters. I think that Avastin is going to maintain a dominant place in the market for years to come. As you know, that it takes a while for people to accept the results of studies. Avastin is inexpensive, easy to acquire, and one of the issues with the Aflibercept at 0.4 milligrams, we don't have a pre-filled syringe. So you're basically looking at a 0.01 ml injection, which is very difficult to assess on a syringe. And in most cases that I've seen of anti-VEGF therapy failures in retinopathy of prematurity, I can't prove this, but my suspicion is that the drug never got into the eye. Okay. Even when you're doing the half dosage of bevacizumab, which is 0.625 milligrams, that's 0.025 mLs, which is a very difficult measure. There's, some indication that after they moved to the pre-filled syringe in Europe, that there have been some anecdotal reports that failures are up. Why? Because people were injecting a little bit more than a little bit less that's associated with the pre-filled syringe.
So what's the future of anti-VEGF therapy and retinopathy of prematurity? What are the next steps?
Well, I think more and more people are going to gravitate towards the use of anti-VEGF therapy. One, we haven't seen a safety signal. There's been a lot of concern about adverse neurodevelopmental outcomes. And then also there's been some concerns with pulmonary function in these children. When historically, if you looked at, comparing short gestational age and very extremely low birth weights, and you have the cohorts the same, we're not really seeing a safety signal. Sometimes we see some trends, but the bottom line is this: small, sick babies are more likely to have adverse neurodevelopmental outcomes and also to have adverse pulmonary outcomes. So it's very difficult to tease out a signal. We haven't seen any dominant signal like that. So I think this is kind of the green light for more people in the United States to start using anti-VEGF therapy. My group and Dr. Noodleman's group and Dr. Campbell's group in San Diego and in Oregon have become proponents of assessing, how much avascular retina is elaborating anti-VEGF as another risk factor assessment at the time of trial, time of treatment, to see if we can bin these patients into more accurate cohorts so that there's more balance between the groups.
Well, that's exciting.
We're very excited.
Thanks a lot for your update in this important area.
Thank you, Carmen. I always appreciate it.
Okay, great. Thank you.